Autoimmune Encephalitis, AIE, based on review by Garg et al. 2020. Autoimmune encephalitis, AIE, is being increasingly recognized as a significant as well as frequent cause of encephalopathy in the pediatric age group. Despite a plethora of antibodies being described against the central nervous system, a significant proportion of childhood autoimmune encephalitis do not exhibit detectable known antibodies, spawning a diagnostic challenge. These children may have as yet unidentified antibodies or other immune mechanisms. AIE incorporates proven syndromes based on clinical phenomenology and based on autoantibody associations. Of these, syndromes with antibodies to cell surface antigens have evidence to suggest pathogenicity. Rarely, antibodies to intracellular antigens can be a biomarker, but their role is unproven. The most common antibody associated with AIE in children is anti-NMDA receptor, NMDAR antibody. Unlike adult AIE, association with cancer is less frequent in children. Early diagnosis and treatment leads to better neurocognitive outcomes. Pediatricians and intensivists need to be aware of this entity so that they can ensure timely and appropriate diagnosis and treatment. This review will provide readers with an updated account of clinical presentation, diagnosis and treatment options in autoimmune encephalitis in children, with discussion of future priorities and challenges. Epidemiology. Data on the epidemiology of pediatric AIE is limited. A retrospective study of anti-NMDAR encephalitis conducted over 7 years in Hong Kong estimated an incidence of 2/million children per year. This disorder likely accounts for a large number of cases of encephalitis in children. Anti-NMDAR encephalitis may also contribute to recurrence of encephalitis following herpes simplex virus encephalitis in both children and adults. Other non-herpes viruses may also act as triggers for anti-NMDAR encephalitis. Anti-NMDAR encephalitis accounts for 4% of all encephalitis and is the most common cause of seropositive AIE in children. Almost 40% of all reported cases are below 18 years of age. Steroid-responsive encephalopathy associated with autoimmune thyroiditis, SARATE, or Hashimoto's encephalopathy has a prevalence of 2/100,000 in adults, but its frequency in children is much less. Anti-thyroid antibodies may be detected in up to 10% of normal children, entailing caution while interpreting these in the presence of neurological impairment in children. Pathogenesis. Autoimmune encephalitis can be categorized as per antigen location into two groups. In one group, antibodies target intracellular antigens, and in the second, antibodies target cell surface antigens. This categorization has clinical relevance as well. Intracellular antigen-based diseases are usually paraneoplastic and are mediated by cytotoxic T cells. These syndromes respond poorly to immunomodulatory therapy with poorer outcomes. Cell surface antigen-based diseases have a lower association with malignancy and are mediated by the humoral immune system. These have a better response to immunotherapy and a more favorable outcome. AIE may also be paraneoplastic or non-paraneoplastic based on the presence or absence of an underlying neoplasm, respectively, although this is less relevant in pediatric AIE. Paraneoplastic syndromes. These result when tumor antigens are shared by neuronal cell antigens, leading to antibody-mediated immunological destruction of neural tissue. Infections. Another mechanism is post-viral autoimmune encephalitis. This was first highlighted in a study that reported the development of anti-NMDAR antibodies in 30% of patients with HSV encephalitis based on CSF PCR studies. It is now known that relapsing symptoms following HSV encephalitis that lack viral antigen positivity may be attributable to anti-NMDAR antibodies in 20% of the cases, with a higher frequency in children. These relapses improve dramatically with immune therapy. A putative mechanism involves the release of brain-specific neoantigens caused by viral toxicity that trigger development of pathogenic antibodies. Another mechanism may be the nonspecific stimulation of a range of antibodies following viral inflammation. In children, these relapses frequently take the form of chorioathetosis and diminished consciousness. Even the viral phase of herpes virus encephalitis may have immunological basis supported by the occurrence of less severe disease in immunocompromised individuals, as well as the beneficial role of steroid therapy in this condition. Although less frequently documented, other viral infections such as varicella zoster, Epstein-Barr virus EBV, human herpes virus 6, HHV6, cytomegalovirus, CMV, adenovirus, rickettsial infection, as well as HIV are also known to predate AIE. Non-NMDAR antibodies have also been reported after viral encephalitis, including anti-D2 receptor, anti-GABA A/B, anti-AMPAR antibodies. Post-vaccinal, several cases of anti-NMDAR encephalitis have been reported following vaccination with influenza, H1N1, diphtheria, tetanus, pertussis, polio, and Japanese B encephalitis vaccination. Clinical features. Pediatric autoimmune encephalitis clinically manifests as various clinical syndromes dictated by the type of antibody. Both paraneoplastic and non-paraneoplastic syndromes are associated with the following broad type of antibodies. I. Antibodies directed against cell surface antigens. T2. Antibodies directed against intracellular antigens. And 3. Antibodies directed towards synaptic antigens present on the extracellular surface. I. Anti-NMDAR encephalitis. Anti-NMDAR encephalitis accounts for 4% of all encephalitis and is the most common cause of seropositive AIE in children. This entity was first described in 2007 as a paraneoplastic syndrome in adult females in association with ovarian teratomas. Since then, it has been described in men, women, and children of all age groups with and without teratomas. Almost 40% of all reported cases are below 18 years of age. Pathogenic IgG1 antibodies bind to the GLUN1 subunits of the N-methyl-D-aspartic acid receptor, leading to their internalization. Clinical features include a prodrome in 50% of cases lasting weeks to months, comprising fever, malaise, headache, gastrointestinal or respiratory complaints, followed by neurological, abnormal behavior, cognitive deterioration, short-term memory loss, seizures, movement disorders, central hypoventilation syndrome, psychiatric delusions, hallucinations, catatonia, and autonomic dysfunction, 23-24. Younger patients tend to present with seizures and movement disorders compared to adults who present with psychiatric abnormalities. Children with anti-NMDAR encephalitis have multiple symptoms, and monosymptomatic cases are present in only 1% of patients, which is why anti-NMDAR encephalitis is unlikely to be a cause of isolated psychosis and is usually accompanied by seizures. Seizures, seen in up to 80% of patients, may be focal or generalized, including status epilepticus, and may occur in any stage of the disease. In a study from New Delhi of 15 patients with AIE, age range 2, 64 years, seizures were reported in 100% patients. Movement disorders include orofacial dyskinesias, chorea athetosis, bulismus, rigidity, opisthotonus, and tremors. Advanced disease is characterized by stupor, coma, periods of agitation alternating with catatonia, as well as autonomic dysfunction. In younger children, behavioral changes may be difficult to discern as they present with temper tantrums, irritability, and hyperactivity, as opposed to frank psychosis. Unlike adults, the first symptoms are non-psychiatric, ranging from dystonia and seizures to mutism. In a study from Chandigarh that studied patients below 12 years of age with anti-NMDAR encephalitis, the presence of extreme irritability, insomnia, and mutism were reported in all the children. 3 clinical phenotypes have been described, viz. The classic form and the psychiatric form, associated with good outcomes, and the catatonia predominant form, associated with poor outcome. Atypical forms have also been described with children presenting with dominant autistic regression, catatonia, and neuroleptic malignant syndrome and gait disorder. The presentation of pediatric anti-NMDAR encephalitis differs from adult AIE in several respects. Overlapping encephalitis. A recent study showed that some patients with anti-NMDAR encephalitis had an overlap in terms of clinical features or magnetic resonance imaging (MRI) findings with neuromyelitis optica (NMO). Syndromes with dual positive antibodies have also started to be recognized for example, anti-NMDAR and anti-MOG, or anti-AQP4 or anti-D2 receptor positivity, anti-GAD and anti-GABA-A, etc. The proportion of anti-GABA-B antibodies with overlap seemed to be more. Among 20 patients with anti-GABA-B receptor encephalitis, 7 showed overlap with other antibodies. Anti-NMDAR encephalitis may also overlap with opsoclonus syndrome. Seronegative autoimmune encephalitis. Only up to 44% of patients with AIE have an antibody-positive status. Seronegative but suspected autoimmune encephalitis has received a consensus definition. The definition includes rapid progression of symptoms, along with exclusion of well-defined AIE syndromes such as typical limbic encephalitis, absence of serum and CSF antibodies, along with 2 of MRI abnormalities suggestive of autoimmune encephalitis, CSF pleocytosis, CSF-specific oligoclonal bands, or elevated CSF IgG index or brain biopsy showing inflammatory infiltrates, along with exclusion of other causes. When to suspect autoimmune encephalitis? The diagnosis of AIE should be suspected in all children who develop a polysymptomatic syndrome encompassing encephalopathy, seizures, movement disorders, psychiatric features, gait disturbances, and autonomic disturbances. The clinical features suggestive of autoimmune encephalitis include abrupt onset, rapid decline, autonomic instability, delirium slipping into catatonia and vice versa, urinary/fecal incontinence, cognitive slowing, gait imbalance disorder, relapse after treatment for viral encephalitis, seizures that may be in the form of status epilepticus or multifocal drug-resistant epilepsy or seizure clusters, involvement of multiple domains, e.g., cognition and extrapyramidal system, etc. CSF may also reveal features of inflammation in the absence of infection. Features that point away from the diagnosis of AIE include a very chronic or indolent course, plateauing of symptoms, no impairment in activities of daily living, cognition remaining intact, purely psychiatric symptoms. Diagnosis. The diagnosis of AIE is based on the presence of an appropriate clinical syndrome supported by various ancillary investigations. All other possible etiologies should be ruled out along with confirmatory antibody testing. The common differentials include CNS infections, toxins, CNS vasculitis, inborn errors of metabolism, neoplasms, and a primary psychiatric disorder. The features supportive of an autoimmune etiology include evidence of CNS inflammation, CSF pleocytosis, 90% sensitive, and 96% specific for the diagnosis of anti-NMDAR encephalitis in children. Diagnostic evaluation includes the following. 1. Magnetic resonance imaging of brain. Classic neuroimaging abnormalities in AIE include unilateral or bilateral T, 2/flare signal hyperintensities involving the mesial temporal lobe. The large majority of patients, 66%, with anti-NMDAR encephalitis do not exhibit neuroimaging abnormalities. Abnormalities in the form of signal hyperintensities may be seen throughout the brain. Transitory cortical enhancement in the absence of restricted diffusion or hemorrhage may also be seen. In patients with normal MRI and typical clinical and EEG picture, positron emission tomography may be useful to highlight involvement of the mesial temporal lobes. In contrast to NMDAR encephalitis, the large majority of patients with limbic encephalitis, such as anti-IgG1 antibodies, exhibit mesial temporal hyperintensities and may go on to develop mesial temporal sclerosis on follow-up imaging. The presence of restricted diffusion and contrast enhancement correlated with the development of mesial temporal sclerosis. MRI is mostly abnormal in anti-GABA-A receptor and anti-D2 receptor encephalitis. Most patients with anti-GABA-A receptor encephalitis show MRI abnormality in the form of extensive, multifocal or diffuse cortical and subcortical T2/flare signal alterations. Rapid progression from frontal and temporal T2/flare abnormalities to atrophy and extensive bilateral lesions has been reported in some patients. Majority of patients with anti-D2 receptor encephalitis Exhibit bilateral basal ganglia, T2/flare signal abnormalities. 2. Electroencephalography. EEG may show focal or diffuse slowing, as well as epileptiform discharges. 30% of anti-NMDAR encephalitis patients may exhibit a typical pattern called extreme delta brush. 3. Antibody testing. Confirmation of the pathogenic antibody forms the basis for diagnosis of autoimmune encephalitis. Those testing positive are deemed definite cases, while those who do not are labeled suspected. These antibodies bind to conformational extracellular epitopes of proteins on the cell surface like receptors, synaptic proteins, or ion channels. Their shape and conformation determine antibody binding. Therefore, cell-based assays with live or fixed eukaryotic cells should be used. The importance of the same was highlighted in the false positivity associated with voltage-gated potassium channel, VGKC, complex radioimmunoassay, because it not only precipitates the target antigens, leucine-rich glioma inactivated, LGI1, and contact in associated protein 2, Casper2, but also other intracellular antigens. Serum testing for these antibodies is non-inferior to CSF testing, except in the case of anti-NMDAR encephalitis, where CSF testing is more sensitive, with CSF sensitivity being 100% versus 85.6% in serum. In addition, commercial anti-NMDAR testing should be done using assays that test IgG antibodies to the extracellular domain of the NR1 subunit of the receptor. Antibodies such as serum, IgA, or other antibody types other than IgG, or antibodies to the NR2 subunit, do not necessitate treatment as these are not clinically relevant. Testing both serum and CSF should be done whenever possible. The utility of follow-up evaluation of these antibodies has not yet been ascertained and is therefore not indicated as of now. If diagnosis is delayed or patients have received treatment with plasma exchange or IV immunoglobulin, antibodies might be detected only in CSF. Patients with a protracted clinical course or persistent symptoms might be seronegative and have persistently raised CSF titers until symptoms improve. Less frequently, long-term follow-up reveals patients who, after recovery, still have high serum titers in absent or barely detectable titers in the CSF. Findings are consistent with a disease in which the immune response is initially triggered systemically by a tumor or other unknown causes and is reactivated and expanded in the CNS. Treatment. Basic tenets that guide the treatment of autoimmune encephalitis are that patients treated with immunotherapy fare better than those not given immunotherapy. Earlier initiation of immune therapy is associated with better prognosis. Lastly, if the patient does not respond to first-line therapy, or if the disease is severe or relapsing, treatment with a second-line agent improves prognosis. The primary immunomodulation options include steroids, intravenous immunoglobulins, or plasma exchange. This may be followed by maintenance therapy in the form of oral steroid taper, monthly pulse steroids, or pulse IVIG therapy. Azathioprine and mycophenolate mofetil are often used in maintenance therapy as steroid-sparing agents. Usual duration of maintenance therapy ranges from 6 to 12 months but is individualized. Second-line therapy in case of non-response to first-line agents includes rituximab. Cyclophosphamide is another second-line agent. Third-line agents include bortezomib and tocilizumab. Another important tenet is to screen for tumors, especially in adolescent females, due to the association with ovarian teratomas. Additionally, clinicians must consider subacute sclerosing panencephalitis, SSPE, in the differential as it is a close mimic of AIE, presenting as cognitive decline, seizures, myoclonic jerks, ataxia, and extrapyramidal disorders. 1. First-line therapy. Corticosteroids form the cornerstone of treatment. They have good penetration across the blood-brain barrier and have a broad spectrum of anti-inflammatory activity. They are usually given as a pulse therapy with methylprednisolone, 30 mg/kg/d for 5 days, maximum 1 g/d, followed by sustained oral steroids according to body weight, prednisolone, 1 to 2 mg/kg day, followed by slow taper over 6-12 months, in severe syndromes like anti-NMDAR encephalitis, determined by case-based scenario. Intravenous immunoglobulin, IVIG, 2 g per kilogram, given over 5 days, or plasma exchange, PLEX, 5 to 7 exchanges of 50 ml kg every alternate day, are commonly used as alternatives and occasionally concomitantly. Evidence, although scarce, has found early PLEX along with corticosteroids to have better outcomes than either alone. No evidence exists regarding the superiority of PLEX versus IVIG. However, considering that patients with autoimmune encephalitis are commonly agitated, IVIG might be easier to administer. In a study from Bangalore, 13 children with anti-NMDAR encephalitis were followed up for a mean duration of 10.3, 6.7 months. All patients were administered intravenous methylprednisolone, followed by monthly pulses of methylprednisolone. IVIG and PLEX were administered during the acute phase for inadequate response to methylprednisolone. The study concluded that anti-NMDAR encephalitis required prolonged immunomodulatory therapy, and methylprednisolone was effective for this purpose. If AIE is suspected, empirical therapy has to be initiated immediately. Waiting for the results of antibody tests is not an essential prerequisite. If resources are a constraint, CSF is the preferred sample for antibody testing because it is more sensitive than serum, especially for anti-NMDAR encephalitis. If the patient is unable to afford antibody testing altogether, empirical therapy should be initiated after reasonably excluding alternate causes. 2. Second-line therapy. A significant proportion of patients respond to first-line therapy, showing benefit of treatment within the first one. 2 weeks of treatment initiation. Non-responders are treated with second-line agents viz. Rituximab or cyclophosphamide. Rituximab is a chimeric monoclonal antibody against CD20, resulting in B-cell depletion, which leads to reduced pro-inflammatory CD4+ and CD8+ T-cell responses. B-cell measurement should be done 2-4 weeks after dosing to check for B-cell depletion. Some children may be resistant, which entails a substitute treatment, and 3-6 monthly thereafter to look for B-cell repopulation that may assist redosing if clinical symptoms persist or a relapse is suspected. Although well tolerated, infusion reactions occur in approximately 12% individuals, and serious adverse events are rare. Dale et al. Reported serious adverse events in 4 children out of the 144 treated with it, including 2 deaths. Cyclophosphamide is the other alternative and has broad cellular immune suppression effects. Monthly intravenous infusions of 500 to 1,000 milligrams per square meter body surface area for 9 months is the usual course of treatment. The risks of infertility and secondary malignancies are the major limitations to its use. However, these are dependent on the cumulative dose received. 3. Third-line agents. Third-line agents are needed when both first and second-line agents fail. Literature regarding their use is limited to general recommendations. Berendt et al. Showed benefit of bortezomib, protease inhibitor, which inhibits the pro-inflammatory signaling cascade, in 2 adults with severe refractory anti-NMDAR encephalitis. Tocilizumab, an anti-IL-6, has also been tried. 51, based on the observation of elevated levels of IL-6 in the CSF of patients with anti-NMDR and anti-MOG associated disease. Tottenklo et al. Have used intrathecal steroids and methotrexate in pediatric patients with refractory anti-NMDR encephalitis, maintenance therapy, mycophenolate mofetil, MMF, methotrexate, and azathioprine have been used as steroid-sparing agents in pediatric anti-NMDR encephalitis. In a systematic review of retrospective cohort data, MMF/methotrexate/azathioprine, used individually or in varying combinations, were associated with a reduced risk of relapse if started after the first event rather than after subsequent ones, and were reasonably safe. Other measures. Symptomatic therapy. Symptomatic management should be given along with immunosuppressive treatment. Sedating agents are used to induce and maintain sleep, relieve agitation, and emotional imbalance. Benzodiazepines, antiepileptics, clonidine, and chloral hydrate are commonly used for this purpose. Neuroleptics are best avoided due to the high incidence of adverse effects like rigidity and neuroleptic malignant syndrome. Management of relapses. Relapses tend to be uncommon in AIE. However, when they do occur, they are managed with repeat dosing of the first-line agents. In these cases, there is concern of ongoing inflammatory activity, and hence chronic immunosuppressive therapy such as azathioprine, mycophenolate, or repeated dose of rituximab may be considered. Prognosis. Most patients with anti-NMDAR encephalitis respond to immune therapy. A study with a median follow-up of 24 months showed that 94% patients responded within 4 weeks to first-line immunotherapy/tumor removal. Of the patients who failed first-line therapy, 57% underwent second-line therapy and had better outcomes. At 24 months follow-up, 81% patients had a good outcome, with mortality in 6%. Outcomes continued to improve up to 18 months following treatment. Predictors of good outcome included early treatment and lack of intensive care unit admission. Relapses in AIE tend to be uncommon, and the approximate percentage varies according to the subtype being dealt with. Approximately 12% of patients with anti-NMDAR encephalitis were found to relapse in initial descriptions. However, this has reduced, probably due to the use of second-line therapies and chronic immunosuppression, which lead to the alteration in the natural history of disease. The patients that do relapse tend to be monosymptomatic, presenting with seizures or movement disorders commonly, unlike the initial presentation, which almost always tends to be polysymptomatic. Chronic immunosuppression with mycophenolate, azathioprine, or redosing with rituximab is done in this scenario. And thanks for listening, and I hope this is helpful for you.